Welcome, everyone. I'm seeing a few people still joining in, but let's get started. My name is Shilpa Venkatachalam. I'm honored to be your facilitator for today's discussion on gout called Get Ahead of Gout, Manage Your Gout Today, and Help Shape Tomorrow's Treatments. Just a little bit of an introduction to myself. I'm the Chief Patient-Centered Research and Ethical Oversight Officer at the Global Healthy Living Foundation, where I also serve as the Principal Investigator on Patient Spot, previously known to many of you as Arthritis Power, which is our omni-disease platform that patients like you can use to track their disease symptoms, manage their medications, so that they can better communicate with their healthcare team and, of course, engage in shared decision-making. Through this app, patients are able to access education, support, and research. Our mission at the Global Healthy Living Foundation has always been to improve the lives of people with chronic disease through better access to care, education, support, advocacy, and patient-centered research. And so, in line with that, over the years, we've been conducting several webinars like this one with the main aim of bringing evidence-based research and information and facilitating dialogues on important topics in healthcare between researchers, clinicians, advocates, and of course, patients. So today we're here to talk with you about gout and a very exciting new study called TRUST, Treatment of Urate Lowering to Standard Treatment, led by Massachusetts General Hospital, or Mass General, as most people refer to it. So this study mainly compares two approaches to managing gout, and the findings could really lead to more effective treatments and improved quality of life. So whether you're a patient or a healthcare provider, this webinar will show you how you can be part of the future of gout care. We want this event to be as interactive as possible. Your questions are really important to us, so please make sure you send your questions. We'll answer as many questions as we can, given that we are constrained by time, and we will try and answer any pending questions at a later point through articles, etc. Now, throughout the webinar, we'll also be showing you a QR code, which you can scan to access a bunch of very interesting and free resources we hope that are helpful to you, and that will be mentioned in this webinar. And on this QR code, the QR code will link to a web page where you can also learn more about the study that we're about to talk about. You can also access these resources by going to a link which will appear on your screen. The link is linktree.ee/gout webinar. So for today's discussion, you'll hear multiple perspectives, including those from a rheumatologist, a primary care provider, a registered nurse, and someone living with gout. Starting this very interesting discussion is Dr. Dan Solomon, rheumatologist and investigator on the TRUST trial. Following him, we'll hear from Ron, who lives with gout, and he is here to talk about his lived experience and is currently taking part in the TRUST trial. Dr. Julian Dedier is our primary care provider on the panel, who will then discuss how he helps to route patients who might need to see a specialist for their gout. And of course, last but not the least, we're joined by Stephen McDermott, a registered nurse who engages with patients in the trial. So very, very warm welcome to all our guests and to all of you today. Looking forward to a very interesting discussion. And why don't we get started? Just to get things going here, we want to assess what information might be most useful to you all who are joining us in the audience. We'll get started with a poll that should pop up on your screen. Question is poll number 1, what causes gout? Okay, and we're seeing answers coming in. And there we go. So all of the above is the majority of responses. And Dan, I want to move to you with this, get your thoughts, first of all, on the answers that we're seeing on the screen, which ones are really factual, which ones are not, and also sort of give us a little bit of information on sort of a 101 on gout. What is it? What are the current treatments? What causes it, etc.?
Sure. Thank you, Shilpa, and thanks for the Global Health Living Foundation for putting this webinar on. I'm a rheumatologist at Brigham and Women's Hospital in Boston, and am one of the investigators on the TRUST trial, which we'll be talking about today. Um, the question that was asked, all of the answers are really quite appropriate. So, gout is a multifactorial metabolic condition that manifests as an inflammatory arthritis. And I think my job in the next 5 minutes is to really try to level set, give the gout 101. So, what is gout? I think gout typically presents as inflammatory arthritis, often in the lower extremities, meaning the foot, the ankle, the knee. It can present in the upper extremities, in the arm, in the wrists, in the fingers. But it's typically in the lower extremities. It's the most common inflammatory arthritis. It affects about 10% of adults in the United States. And it's associated with elevations in uric acid. Uric acid is a part of the blood. Everybody has uric acid in their blood. It's measurable in all humans. When the levels get high and stay high, the uric acid actually comes out of the blood and it forms crystals around the joints. And those crystals that form around the joints can be the initiators of inflammation in the joint. So an inflammatory arthritis is inflammation in the joint. As people who many of you have experienced gout flares, gout attacks, it's very painful. It can come on suddenly, often in the nighttime, and without proper treatment, it can last for days, sometimes weeks, and it can be very disabling. So that's a little bit about what is gout and what causes gout. We know that certain diets are associated with elevations in uric acid, but probably the most important reasons why people have elevations in uric acid is not your diet, but it's about your genetics, what you inherited from your parents. And so 50 to 60% of the reason why people have elevated uric acid is about your genetics and not about what you eat. However, it is true that you can help to lower your uric acid and you can help to lower your risk of having a gout flare by avoiding certain foods. And there's a lot of information online about different foods that you can learn about. And I'm not going to go through all of that today, but diet is important. Genetics are important. Uric acid is important. And additionally, some medicines are associated with elevations in uric acid and gout flares. So it's a complicated metabolic condition, the most common inflammatory arthritis. And what you're really probably asking yourself is what can I do about it? There are things to prevent it. Changing your diet can be helpful. Staying hydrated can be helpful. Watching out certain medicines and speaking with your physician if you're worried about certain medicines maybe causing your gout or associated with flares of your gout. And then there are certain medicines that can help reduce the risk by lowering uric acid. And then when you have a flare, there are really good medicines that help to quiet that flare down. So we know that medicines that are anti-inflammatory, like ibuprofen, Motrin, or naproxen, Aleve, or a steroid, prednisone, or colchicine, are very commonly used medicines that can help if people have flares. So that was my attempt in just a few minutes to give you an overview of gout. And so we're all on the same page as we kind of navigate through the next couple of talks where we hear different people's perspectives.
Wonderful. Thank you so much, Dan. That was really helpful. And, one of the things that you said is this assumption around alcohol. Before we move to our next panelist, if you can just tell us a few sentences about the link between what is known as to the role of alcohol and gout, and not specifically beer, alcohol in general. That's one of the questions that's
Sure.
coming.
Yeah, so people have studied this very intensively, and it's known that beer and spirits are definitely associated with gout and gout flares. Um, I'm going to tell you though that we've just conducted a large study where we show that reducing or cutting all alcohol out lowers the uric acid by just a little bit. It seems like the reason that alcohol is associated with gout is probably because it dehydrates people. It's a diuretic. Alcohol is a diuretic, and diuretics, when our volume of fluids in our body is reduced, gout flares are triggered. So it is important to limit alcohol use, but a lot of people and even doctors have the mistaken feeling that it's about lowering uric acid. It's probably about dehydrating or volume depletion that happens in people who have had a lot to drink.
Wonderful. Thank you, Dan. So with that, let's pull up the next poll and then we can get Ron in here. So you should see poll 2 on your computers. Do you see a rheumatologist for your gout? This is a single choice answer, so it's a yes or no. Having great interaction in the text box as well. So thank you for sharing where you're joining us from. And there we have it. So overwhelming number here, 54% say yes, they see a rheumatologist. And this is a great way for me to move to Ron. Tell us a little bit about your own journey, how you got diagnosed, how you got routed to the right care, what kind of treatments you've tried, etc. So Ron, take it away.
Well, I am 80 years old, 81 actually. I was diagnosed with gout approximately 15 to 20 years ago. I actually think I had flares prior to that, but I always attributed them to pasher fasciitis or irritations in my shoes or various athletic strains that I might have had. And it got to be a problem. Without medication, I could basically stop eating or drinking or whatever it was, but I never thought it'd be gout. Rested, maybe a hot bath, some Advil, the symptoms went away. But I did get an irritation one summer that I really felt was an infection in my foot. I went and saw my primary care physician at the Mass General, and the nurse practitioner told me that I had gout. She thought very surely I had gout. I was going to do a blood test. I had always equated gout with being a rich man's disease, and I told her I wasn't even close, but she was right. I had gout, just borderline, and she prescribed colchicine. I have noticed over that period that certain foods, and I'm pretty cognizant of what I eat, I get plenty of exercise, that certain foods would cause a moderate flare, just an irritation, nothing that would be disruptive to my everyday activities. But I was surprised when they asked me to be included in this trial. And when I did find out it was arthritis, a form of arthritis, and became aware of some of the food products that triggered it, I was hitting all the bases there. Loved oysters and shellfish and heavy beers, and it was a slight moderation in my everyday life, but it wasn't anything over the top. And I thought, I'm fine with it. But when I was asked to participate in this program, I'm learning more all the time. And I think I'm going to be just fine. But I think there are a lot of people out there that might have gout symptoms or gout and not realize it. And I think this is an important information point for them.
Great. Thanks, Ron. I have a bunch of questions for you. And, first of all, thank you for sharing your experience with gout so generously with us all. We'll come back. One of the things I wanted to ask you before we go to Dr. Julian Didier is, what's your experience been? Have you found that you need to make a lot of decisions with your doctor? And what's really helped you to make those decisions around whether it's what medication to get on, non-medication sort of changes in your lifestyle that you alluded to, or then even the clinical trial that you referred to, that you joined? Do you speak to your doctor about all these decisions? Is that kind of shared decision-making very important to you, I suppose?
Well, I've mentioned it to my doctor, my primary care physician, but just in passing, because I've never had a real flare-up that has occurred. Since I saw my nurse practitioners in my GP's office, paid attention to the listing that she gave me. And I've never had a flare-up that's been that critical that I'd call my doctor about. But it did impede some of my cycling activities. It was there. And now that I'm being cognizant of those dietary problems, I've been fine. Maybe a modest irritation. It's really ironic, some of the things that I could eat and give no attention to, and then notice that a day or so later, oh, I shouldn't have two ice cream sandwiches, what have you. Doctor, I'm sorry, but alcohol, I don't attribute it to alcohol at all. I'm very moderate in my alcohol consumption, but geez, I don't know what I'd do without a good martini and a glass of scotch once in a while. And I try to stay as hydrated as possible if that's the case. Thank you for that information.
Wonderful. Thank you, Ron. And you said something that's really, which is where I want to bring in Dr. Julian Dedier, who is our our primary care specialist who's joining us today. And there's a question, actually, we'll bring up another poll in a second, but Dr. Didier, just to sort of contextualize this, a question has come in about seeing a podiatrist. Ron talked about his primary care person. Can you tell us a little bit, once we put up the poll and, once you've sort of assessed the answers as well, about what the route is that you've seen with patients who come to you? How do you route them to the right care? How do you sort of diagnose or pick up those red flags that might indicate to you that someone might have gout? But I'll stop there with that question, and let's bring up the next poll. There you go. Poll number 3. How would you describe your relationship with your healthcare provider? Something that Ron's talked about. And the reason we're interested in this is to really talk about the role of shared decision making and evidence-based information to equip our patients with information to help them make informed medical decisions. So that's your poll 1. And then the question for poll number 2, or I guess a subpart to pool 3, is how can a patient work with their doctor to get the best gout care? Dr. Dedier, I'm actually going to ask you this time to comment on the responses, so please take it away.
Certainly. Thank you, Shilpa, for having me. So the first question, how would you describe your relationship with your health provider? And it looks like the majority, or at least the plurality, feel like it's a partnership where you can ask questions and share information. And I think that is ideal for gout, as the next case that I'll describe will show. It's mostly a one-way street, only 21%. And I think it's always difficult for a provider to know exactly how a patient feels and to take the guesswork away to really improve the relationship and the care that folks receive. This one-way street is not the best way to approach gout care. Question number 2, how can a patient work with their doctor to get the best gout care? Choose the single best answer. Check in about behaviors that affect gout flares. Nobody chose that, but that is actually a way that patients can work with their providers. Ask why the doctor recommends one treatment over another, for sure. But really, all of these answers are ways that a patient can work with their doctor to get the best gout care, including asking about potential side effects. Shilpa, your question to me was, how is gout diagnosed, essentially? What are the clues? So we've heard an excellent presentation from Dr. Solomon on the symptoms of gout, basically, and also from Ron, who talked about his experience. Really, it's pain in the joints. And there are classic presentations like pain at the base of the first toe, for instance, that's very, very excruciating, such that even bedclothes or sheets will aggravate it. But gout can be very subtle as well. And I think it takes a high index of suspicion to be able to diagnose gout. But gout tends to occur in a constellation of other symptoms or other health conditions, as we'll see in the case of JW. So this is a patient of mine. This is not his picture, but this is one perhaps more dramatic presentation of gout that you might see. So Mr. JW was a 50-year-old man with severe hypertension, obesity, high cholesterol, and kidney stones. And he presented one day with acute left knee pain, which on exam was very warm to touch and extremely tender. So the diagnosis of gout was entertained, and fluid from that inflamed knee was withdrawn and looked at in the lab, which showed 36,000 inflammatory cells, which is a lot. There was also the gout crystal, monosodium urate crystals that were seen in the fluid. So with his constellation of symptoms and these laboratory findings, we were able to make the diagnosis of gout. However, his medical profile is really consistent with someone who might be at higher risk for gout, with the high blood pressure, the obesity, the high cholesterol as well. So Mr. JW was treated with indomethacin, which is an anti-inflammatory medication like Motrin, and hydrochlorothiazide, which is a medicine he was taking for his high blood pressure, which happens to predispose to gout flares, was actually stopped at that time and switched to another blood pressure medication. He was educated about gout so that he could become an active player in his own gout management. And with these interventions, his gout pain did resolve after a few days. But after that, he did have occasional flares of his gout, which he knew he could treat with indomethacin all by himself. So this was part of the power of educating JW about gout, what causes it and how it's treated. He was actually able to take over the treatment of flares as they arose without necessarily contacting his doctor every time. But over time, he did develop heart failure and kidney disease. So indomethacin as a medication became a little riskier to use because of those conditions. So he was put on colchicine for flares instead. But he still had a large supply of indomethacin at home, and it turns out that he would use both depending on which joint was affected. But the next development in his case was that he developed nausea, thirst, urinating all the time. He came into the emergency department and his blood sugar was over 600, consistent with a new diagnosis, diabetes, which is another metabolic condition like gout, which tends to travel with gout. So after that wake-up call, he met with a nutritionist. He radically improved his diet. He lost a lot of weight. He began to exercise 1 or 2 hours, 3 or 4 days a week. And he also decreased his intake of seafood, which he observed was a trigger for his gout. And with all of those changes, he was able to come off the insulin, and he had fewer gout flares as well. But in the months that followed, his gout flare frequency did increase. And at one point, he reported having 4 flares in the last 12 months. So he became a candidate for prevention of gout flares instead of just treating them as they come up. And what we recommended was allopurinol, a medication that many folks have commented on in the chat, and colchicine to prevent gout flares. But he wanted to think about it because there are risks, potential risks involved with these medications, although they're generally well tolerated. So when I saw him back, he was more or less willing to start the allopurinol and colchicine, but in the interim, he had been started on a heart medication, which had serious potential interactions with the colchicine. So we reached out to his cardiologist for a little bit of guidance. So that ends the case of JW. What I'd like to do is transition to some of the thoughts that come out of this case. And then in the next couple of slides, just observations I've made as a primary care provider treating gout over the last 20 years. So JW developed gout in the setting of other metabolic health conditions like obesity, high cholesterol, high blood pressure, and diabetes. And the point here is that having one of these metabolic conditions puts a person at higher risk for others. But lifestyle modifications like eating a healthier diet, getting enough exercise, losing weight, all of those play a part in the management of not only gout, but also these other metabolic conditions that go along with gout quite often. And next, it's important to be clear on the different medications, how to use them, their potential side effects, and potential drug interactions. Often people with gout have other medical conditions that are treated with medications, and there are potential drug interactions that can occur, which one needs to be aware of. So next, I'd like to share some of my observations about gout treatment in primary care, which is where a lot of gout care does occur. Number one, gout care is a shared decision-making process between the patient and the provider. It starts with education. So gout is one of those conditions where education is key. Patients need to know what triggers gout. They need to know what gout flares are, sort of identify those symptoms. And the earlier they can do that, the earlier they can initiate treatment for gout so that they can shorten the gout flares. So education and self-management are both key. Number two, medication side effects and sort of knowing what they are is also very important. It's important to know that certain medications are associated with certain side effects, such as the anti-inflammatory medications in the class of medicines with Motrin can cause ulcers, they can cause problems with the kidney. They're generally very safe medications, but one should know about the side effects that are possible. And then sometimes the strategy involves taking medications to lower uric acid. It's important to know how those medications can interact with other medications and what potential side effects might be, such as rashes and other more serious side effects that can occur. And then finally, it's important for patients to let their providers know what's working and what's not. So for instance, JW was convinced that colchicine worked better for his gout in the legs and the ankles, the toe, and that indomethacin worked better for his gout in the wrists and in the elbow. So it's good to let the provider know exactly what's working for you and what's not. Okay, and then a few thoughts on treating gout flares. So as I mentioned, it's important to treat gout flares early so that they don't last as long. And for that to happen, a patient needs to have the therapies on hand, like the Motrin, if that's what they're using, or colchicine, rather than trying to contact the primary care office to get these medications after the flare arises. So it's important to have good communication so that with the primary care provider, so that you will have your abortive medications on hand when you need them. So then there's some thoughts for people who are on a urate lowering therapy. I guess the point here is don't get lost. So one common pathway to treat folks with urate lowering therapy is to check the serum uric acid level in the blood. That's the level that that allopurinol is trying to reduce. And then to prescribe the allopurinol and then to recheck the serum uric acid to see if it's low enough, and then if it's not low enough, to increase the dose of the allopurinol. So there is that process of increasing a dose of allopurinol and checking the blood to make sure it's working. But often patients, they get lost in that. The provider may forget to either increase the allopurinol dose if the dose isn't sufficient, or to check the blood level of uric acid. And so it's important for the patient to remind the provider, that, listen, we're still trying to get to the right dose of allopurinol. Do I need to check my blood again today to make sure we've gotten to the right spot? Along with the allopurinol, you'll be prescribed another medication for the first 3 to 6 months to make sure, or to reduce the risk of a flare happening while the allopurinol is taking effect. And so I found that it's important for patients to understand that they need to be on that medication for about 3 to 6 months. Sometimes patients want to stop that medication before the 3 to 6 months. Sometimes they run out of it and they're not aware that they need to renew the medication. Sometimes they take the medication for longer than 3 to 6 months, which is something that they don't typically have to do if they've already reached a steady dose of the allopurinol. So keeping track of that detail is also very important for patients. So the final slide here is that all that glitters is not gout, which is to say that even though you may have gout, which causes pain in the joints, if the gout flare is a little different than your typical one, it might be something else. So for instance, if you don't usually have fevers, chills, and sweats with a gout attack, and usually those things don't occur, then you might be dealing with an infection. Just like Ron thought that maybe he had an infection in his foot. It could very well be that this is an infection and not gout. Or maybe there are new joints that are involved, not your typical joints, or multiple joints are now involved. Or maybe there's a new rash that's associated with your joint pain. These things may not be gout. So at those points, it's good to reach out to your doctor just to make sure.
Wonderful. Thank you so much, Dr. Didier. That was a fantastic overview. I just, before we come to Stephen, just want to acknowledge that there's people joining us from everywhere. So thank you again to our audience for joining us. We have people from England, Malta, the US, of course, Alabama, New York, East Coast, West Coast. And we're getting some fantastic questions. And I see that Dr. Solomon has answered some of those questions. One that came in is about what the blood test is to check for gout. and Dr. Solomon to just want to reiterate your response there, which is that serum urate, uric acid is the common blood test used to see if someone is at risk for gout. Elevated uric acid does not prove that joint pain is from gout. So I suppose what you're saying is it's a combination of clinical tests, biomarkers, as well as sort of talking to the patient, etc. I want to leave us some time also to talk about the trial, really, which goes back to this idea of treat to prevent and treat to target. And we'll come back to that. But before that, I want to bring in Stephen McDermott, who is very closely associated with the trial. So let's pull up our poll. There we go. Is there a special diet for gout? Right? And can we get the responses, please? There we go. Dr. Solomon, I'm going to let you take it away and maybe even provide a couple comments on the responses, please.
Sure. Diet for gout. I touched on this briefly. There are definitely foods that are lower in uric acid, and people can control their uric acids by a little bit. The most strict diet can reduce the uric acid by about 2 points, which is quite substantial. So it's important to learn about how to avoid certain foods that might elevate the uric acid. And then there are foods, like Ron told us, that might be triggers. A lot of people find that shellfish and other seafoods are triggers for them. So there's kind of two dietary issues. One is foods that might elevate the uric acid, and the second one is foods that might trigger an attack. And those are both important to be aware of.
Fantastic. And Dr. Solomon, do you want to talk a little bit, maybe give us a little
Sure.
review about the trial?
So the TRUST trial is NIH funded. It's funded by the federal government. And I'm one of the principal investigators, along with some colleagues at Mass General Hospital. And we have a very interdisciplinary group with primary care doctors and rheumatologists. And we've had patients and nurses being involved in the development of the trial. And we're trying to get at the question that Shilpa mentioned a minute ago, which is whether the optimal strategy for managing gout is treating to a target serum urate versus treating to, when people have symptoms and flares, giving them anti-inflammatories. Those are the two competing strategies that are most commonly used in the United States, but we don't really know which is the optimal strategy for the most people. Again, the primary objective, as noted on this slide, is to compare the rate of gout flares across these two treatment arms, treating to a target serum urate or treating to avoid symptoms. And we're also looking at quality of life. And then a number of the other metabolic conditions that Dr. Dedier mentioned, glycemic control or diabetes, blood pressure control, kidney function, as well as coronary artery disease. So it's a really very broad-based study that we're conducting. And the next slide gives just a little bit of a design. We screen patients who seem like they may be good candidates and are interested. You come in and you sign a consent form, and then we have about a half an hour visit where we do a brief physical examination and draw some laboratories, and we see whether people meet all of the criteria and are still interested in participating. And then they would be randomized to one of these two arms. Randomization means you can't choose. It means as a flip of a coin, and you might be in one arm treating to target serum urate or the other arm treating to avoid symptoms. And then throughout the 2 years of follow-up, we have visits about every 3 months. Some of those can be virtual, so they're done by Zoom, just like tonight, or some of them you come in for and get a blood draw. We send people their medicines, so all the medicines are free, all the laboratory tests are free, and you get expert care by trained nurses like Steve in each of the arms. And so it's really great. The patients who are participating, like Ron, I think are generally very happy to participate because we're learning a lot and they're getting excellent care. So this is just a little bit of detail on treat to target serum urate. As you can imagine, we give people a urate lowering therapy. Most commonly, that's allopurinol. For some people who can't tolerate allopurinol, it's a medicine called febuxostat. Patients get colchicine, which is to prevent flares while we're lowering the uric acid, they get lifestyle and diet education and coaching. And then the treat to avoid symptoms, they don't take allopurinol every day. They get all their anti-inflammatory medicines for free. They sent home with those medicines. And then if they have a flare, they'll take the medicines. They get lifestyle, diet, and educational coaching from the nurses as well. So again, everybody's getting good care. We're just comparing this question of whether we should treat to a target serum urate. The study medications which have been mentioned, allopurinol, febuxostat, colchicine, naproxen, and prednisone. So none of the medicines are experimental. They're all tried and true. They've been around forever. And, we understand their side effects. We're very comfortable managing those issues, and people are getting the medications for free. We communicate with your primary care doctor just to make sure there's no issues. And this has been a pretty seamless process for the first 40 patients or so that are in the trial. So that's me. I'm D. Solomon at bwh.harvard.edu. Happy to take your emails. My numbers are there. You can text me on my cell phone if you want to learn more. I'll have one of our study nurses reach out to you and explain the study. But we're excited to educate people who may be interested in participating.
Wonderful. Thank you so much, Dr. Solomon. And, the participation of the patient community is, of course, very important in advancing our understanding of these diseases. I know we're running short on time here and we have a bunch of questions. So I will apologize in advance if we're not able to answer each one of them. But I do want to bring in Stephen McDermott here. Stephen, can you tell us a little bit about what you're hearing from patients who are participating in the trial, concerns, apprehensions, or just their experiences, and how you address some of those concerns?
Well, thanks for having me, everybody. My name's Steve. I'm a nurse working at Mass General, and I manage the treat to avoid symptoms arms at both the Mass General and the Brigham and Women's now. So patients come to me with all sorts of things, different levels of knowledge coming into the trial. Rules of things, so people have some misconceptions. They get offline. I have to kind of try to understand where they're coming from their perspective with their gout. I know I can review the medical record, but as Ron had said earlier, a lot of times they'll have a minor flare and not bother calling the doctor for anything. So there's more that we don't know about. So it helps me to get their perspective about their gout. While I'm doing that, I'm always assessing their knowledge level at the very beginning so I can know where I have to go with my teaching and how much teaching would need to be done. We review the triggers that the participants can control themselves, avoiding the Hyperion foods, as everybody's talked about, avoiding it, overdoing it with alcohol, avoiding dehydration, and then some of the discussions about the non-gout medications that can affect their gout treatment and their gout in general. So we work to develop an individualized treatment plan for each patient. We use their past experiences with managing their own gout prior to the study. We take into consideration all their other medical issues as well, and we come up with a treatment plan. Again, as Dan had said a minute ago, we really, I think Julian may have said this too, the importance of initiating treatment promptly at the beginning of symptoms is stressed repeatedly as we try to decrease the severity and the length of each flare when they do come up. We go over how to treat stubborn flares with the patients, and as you see here, we have handouts for each medication that we do send home with the patients. This is the example for colchicine. If you read left to right, you come up with symptom onset. The middle column is medication instructions, and the last column is any side effects and when to stop taking the medication and call study staff. These are provided in paper form and electronic form to all the patients. And they're for each drug that the patient would be on. So if we sent a patient home on colchicine and a backup of prednisone, they would also get a sheet like this for prednisone. And lifestyle changes are another important thing we try to engage patients in doing. Again, each patient's individual, and they show up with all different levels of activity and abilities. Some people are already active every day, and some people aren't active at all. So we have to work within those limitations of those who can't, and keep encouraging those who can. Alcohol is one of the things that I get asked a lot by patients, and I understand patients are not going to all just quit alcohol. So what we do is we try to come up with strategies for minimizing the effects. And one of the big ones I usually try to offer is to include 1 drink of water with every drink of alcohol. And that kind of accomplishes 2 things where you're drinking a little bit less, but you're also avoiding the dehydration that comes along with the alcohol intake. So everybody's encouraged to increase their fluid anyways, but especially if you're going to be drinking. Of course, there are people that are on fluid restrictions. We don't encourage them to drink as much water. So that's what we do. And I know we're running this short on time, so I will hand it back.
Thank you very much, Stephen. Again, really important information. And, this trial, of course, is very important for clinicians and researchers to understand how to treat and manage gout better with their patients. Ron, we have just about 10 minutes, but just maybe I'll give you the mic back for maybe 3 minutes. Could you tell us a little bit about your experience in the trial? Because listening in our patient community also, and there's a lot of concerns, right, about joining a clinical trial, a lot of apprehensions, etc. So can you share a little bit about what your experience has been in this trial so far?
Well, initially, when I was asked to participate in it, I really didn't think that the gout was that big of a problem because I had become very cognizant of what was causing my irritations in my foot or an ache and pain that would show up in my knee or what have. And Guinness was not a beer that I was going to be drinking quite frequently. Actually, I didn't drink much beer at all. I was moderate in my alcohol consumption. And I really didn't think that, gout was a problem for me. And when they reached out to me very nicely, it made it very accommodating for me to get tested and take part in the program. I just happen to live close to a lab, so very rarely do I have to go into Boston to go to a study, be tested, which is a challenge in itself going into Boston. But no, it's been very accommodating, and everybody's been very nice. If this is what would help in research of the disease, I'm glad to participate.
Wonderful. And thank you to people like you who are participating. It's we who should be thanking you for participating in clinical trials, in studies like this to help us understand the disease itself better. So thank you again, Ron. Last poll up on the screen, but I do want to get everyone in at this point, and maybe we can do a round robin here. Want to ask you, in your opinion and from your perspective as a clinician, as a rheumatologist, as a registered nurse, and as Ron just talked about his patient perspective, why is this trial important? Why should people join this trial?
I'll start. Probably because I'm the most emphatic. Having worked on getting funding from the federal government for 7 years, we don't know the best strategy for managing gout. And rheumatologists who are joint specialists have always assumed that lowering uric acid is the best strategy. But as Julian and others know, lots of patients have mild gout and they have uncommon attacks once a year, twice a year, once every other year, and they manage them quite well with colchicine or non-steroidals like naproxen. And we need to understand what the strategy should be that we as clinicians talk about with our patients. We need better information so we can educate patients in a more holistic manner. And it's probably the case that some patients should be on uric acid lowering therapy and some do fine without it. And I think we need to understand who those patients are so we can be, better partners with our patients. So that's some of my intellectual play about the importance of the trial.
Wonderful. And Dr. Didier, do you want to go next? And, just looking at the poll, you can see that this is a very engaged community. Patients want to help. People who live with this disease and other diseases, and we've noticed this a lot in our own work at GHLF, people want to help you understand the disease better. Researchers understand the disease better. So just your thoughts on why you think this trial is important for patients to participate in.
I want to echo Dan's comments and just to add that one other thing we don't know is whether following the uric acid level down as we treat with allopurinol is really the right approach. Because there are a lot of primary care providers who will prescribe allopurinol, and they may prescribe it without necessarily targeting a specific uric acid level. And gout flares may go away after they've increased the dose to 200 milligrams a day or 300 milligrams a day. And that's good enough for them and for the patient. So I think there are things that we do not know that this trial will help us to determine. It takes work tracking uric acid levels every 6 weeks or 4 weeks. Or, if we don't actually have to do that in everybody, then that would be good to know.
Oh, thank you. And, it's interesting to see the responses. A lot of people are saying if they thought the topic was important, they would participate. So there is that desire to help the community, future generations, etc. Stephen, any closing remarks from you on the trial?
No, for me, it actually gives me a chance to work individually with each patient pretty closely. I'm available to them pretty much all the time. So if they have any questions or concerns about anything study related, and sometimes they may not be study related, it gives me a chance to interact with them and teach them more about A, their gout, but B, just their lifestyle, try to get them on the right track, and so in terms of exercise and diet, and try to avoid flares in the future. So it's good for me, and I think it's good for them, and I think everybody learns, and I just really appreciate all the patients that actually participate.
Wonderful. Thank you. And I'll request the audience, there were large majority who said that you'd like to participate. There was some people, there's a significant portion there who said they have some concerns, etc. So if you want to send your concerns through the text box, the reason I'm asking this is so that we can help to design, maybe not, immediately, but perhaps we can address these concerns and make clinical trials, make studies like this more patient-centric and more suited to you. So if you're comfortable enough sharing, please go ahead and share those in the text box. Unfortunately, we're running out of time here. We have 3 minutes left. I do want to say, I wish we had another 2 hours because this was such a fascinating and insightful discussion. So very, very big thank you to all our panelists. And of course, most importantly, to our audience for your questions, your comments, and sharing your experience. Someone asked in the text box if this webinar would be recorded. The answer is yes. And we will post it on the Webtree, sorry, not the Webtree, the link that you see up on your screen, or you will see up on your screen shortly. So you can go back and refresh your mind with any of the pieces of information that were shared in this webinar. If you're also interested in learning more about gout and attending other webinars, accessing support resources, joining a community of others like yourself living with the disease, or joining the TRUST trial, please scan the QR code that you see on your screen. You can also click on the link in the chat box or then visit us at www.creakyjoints.org/gout. Once again, thank you very much. Sorry if we were unable to come to your questions. We really did run out of time here. We'll try and address them through an article or a post-webinar Q&A. But thank you very much. And to our panelists, thank you very much for sharing all this insightful and fascinating information. Very good luck with the trial. We hope management of patients gets better as we move forward. So thank you very much, everyone.